Well, thanks for tuning in to the online-only version of this panel. So I'm really excited to spend a little bit of time bringing the surgeon's aspect into how we look at how we use 3D modeling, and in particular in the field of otolaryngology, also known as ear, nose, and throat surgery, which is what I do. And I am primarily an airway surgeon, but I definitely spend some time all over the head and neck. And we're going to talk about how the 3D modeling has really gone from being just pretty pictures and cool toys that we like to show our patients and to show our friends, to how it really makes a difference in the operating room. I'm fortunate to be the director for the Center for Pediatric Aerodigestive Disorders and Airway Surgery at Rady Children's Hospital. We serve as a tertiary referral center for kids with breathing and swallowing problems. Kids come to us from all around the world for us to be able to provide both medical and surgical improvements to their conditions. Now we all have to start somewhere, now don't we? So where did my surgical career begin? Was it my Atari 2600 playing Pong for all hours? Or was it moving up to the Nintendo 64 playing Zelda for way too long? Or was it really stepping back? Was it coming into my college dorm room, a bunch of guys all gathered around because I just spent more money than I possibly had, cracked open my 486DX machine, put an extra 4 megabytes in to bring me to a grand total of 8 megabytes of RAM, so therefore I could actually play Doom and be able to track along and see that 3D game as I go through and shoot everybody in sight. Where did it all begin? So where it all began may be irrelevant. This is where we play Doom now. We play it at a little bit higher stakes. We play it as a group. We press buttons a lot, and we watch very closely on the video screen. But at the end of the day, we do all gather around very much like we did in that dorm room. As we step back and we think about the old way, the way that I was brought up and taught surgery, we spent a whole lot of time drawing on paper. Some of us are better artists than others, but at the end of the day, it's all 2 dimensions. Sometimes it worked really well, sometimes it didn't. And this, you're going to have to take my word for it. We're looking at some pipes on the left, all drawn out. We're looking at pipes on the right after surgery, and when things had gone awry. And really what it came down to is trying to understand the 3-dimensional anatomy. That is a key part to being able to perform surgery. And it's something that to have in your mind's eye is both a talent, a skill, and a challenge. Because at the end of the day, when we're taking care of children, it is much more than just a drawing. These are our kids, these are our babies. And while I may be a plumber just on the high end side of things, at the end of the day, I have the privilege to take care of people's children. And so we take a child like this, who came to us, looks so beautiful, looks so cute, but there's a whole lot more going on inside. Okay, before we go on, I just want to give everyone a warning that the following slide does contain a video of a camera inside a child's airway. We're going to be looking down the pipes that head down to the lungs. So, as we proceed down the windpipe, we come down to a problem. So just like walking through the tunnels of doom, we walk into what is truly a tunnel of doom for this poor child. And while that picture before, very cute with a breathing tube, there was something much more sinister going on down below. And this is what we were seeing, a severely narrowed airway. So when we look at how do we take care of these children, there's so much to go on. There's so much to consider and so much to work from. We're able to use a variety of different techniques. This here is using x-rays to be able to get a good view under fluoroscopy to be able to see what the airway tree looks like. And this you're going to have to take my word for it, but it's severely narrowed and doesn't just split into a right and left. There's a major abnormality down below. Now, we take this to the next level where we're able to take a CAT scan. What the CAT scan does is allows us to be able to roll through and be able to see cross-sectional anatomy. Still 2 dimensions, but getting us in the view to be able to start thinking in 3 dimensions. Using the skills that have been brought to us by Justin and his team, we're able to build 3D models. And these 3D models start getting us an idea of what exactly it is that we're dealing with. Because at the end of the day, how are we going to take care of this child? Ultimately, it ends up in my hand. And here it is. This is the true size of that child's windpipe. Hard to believe when you think of what size when you look at a child's head and you look at those nice pictures. But the reality is this is what what a windpipe looks like on the inside. And this is how large it actually is. So somehow we are going to have to take that area and we're going to have to make that larger and make it so this child can breathe. So that's all well and good. We can build models. We can build in lots of different types of textures, some that are realistic, some that are not realistic. We have cool videos, lots of great things to show. Well, yes, I definitely agree. These are very cool toys. They're very cool images. But I think probably the more important question is, what do we do with all these cool things? One of the great things to do is really to be able to tell the story to the family. It's one thing when you show a CAT scan, you show an endoscopy, you show pictures that people can't relate to. However, when they can actually hold in their hands their child's airway, be able to see on a computer screen the three-dimensional aspects of their heart, this is very, very powerful, particularly when we're discussing some of the most difficult surgeries to perform and being able to show families that in real size, how tall, how large, how small, how wide, different aspects of their airway and their body are. It's critical. I love that we are now able to train our residents and fellows on surgical techniques and handling of instruments far before they get to the operating room. They now have the opportunity to get to know the instruments, be able to understand the tissue planes, understand the three-dimensional problems that they are going to be facing when it comes to operating on these airways, far before they get to the situation in an operating room where the stakes are much higher. The ability to practice and understand before getting to the operating room has been shown in a variety of studies to increase surgeon confidence, and then also to be able to allow a method of planning that allows the surgeries to move smoother and decrease the amount of time it takes to perform the actual surgery, because many of the surgical decisions are made preoperatively. These models are applied all over the body into all types of surgeries. In otolaryngology, we do a fair amount of ear surgery, and this is a model that helps teach us ear surgery, and in particular what it has the ability to do to ultimately be able to place sensors to be able to help understand the residents and the trainees to understand when they've gone through critical structures. So does all this actually change anything in the operating room? What do we do when we get there? Well, as mentioned before, the ability to plan your surgeries beforehand has proven to really save time and to also improve surgeon confidence. But there are other things that 3D printing can bring to us. Implantable devices, surgical guides. As I mentioned, surgical planning in terms of surgeon confidence has become a well-accepted benefit of 3D printing. And furthermore, the ability to be able to determine the location of the incisions, the lengths of the incisions, and the ability to do different types of procedures has been really helpful, particularly in the airway world. Surgical guides represent another application of 3D printing. In this situation, you take a 3D model of whatever it is that you are going to try to determine how to place specific cuts. In particular, it's found the most use in orthopedic and bone surgery, but it has also found utility in vascular and airway surgery. You can see here that using the 3D models, the planning is made on where the proper cuts might be, whether it's for removing a tumor, reconstructing a jaw, whatever it may be. The difference here is that this is showing before the incisions are made. This is showing without soft tissue in the way, and sometimes it can be very difficult when we've got muscles and nerves and blood vessels all around to be able to determine the exact places for the cuts. By building a model beforehand that you can actually place on the bone and be able to drive your incision in your cuts becomes a very important and powerful tool to make sure that you aren't just eyeballing things in the operating room. Perhaps one of the most well-known applications of 3D printing is actually building custom devices that are implanted into the children. The airway specifically actually did draw a lot of attention on major news outlets several years ago, in particular because it is a way to be able to custom make an airway scaffold that is used to be able to place directly onto a child's airway through the chest. And while the ability to make something custom made does require a fair amount of work, the fact that it can be bioresorbable so that when children grow and be custom made for them has significant applications. Ultimately, when you think of these different applications in the OR, really what it allows us to do is be able to innovate. And I think that's one of the things, to be able to think beforehand and be able to, before you walk into the OR, be able to take all these different information. And being at a place that really encourages innovation like I am allows us to be able to save the children who we would not have been able to save before. We'll take a couple of cases and just take a look. So this is a 2-month-old. This is a 3D image of a 2-month-old who was born with a single lung, complete tracheal rings, and a vascular ring. Like, what does all that mean? Basically, it means that they're pretty far up the creek and they're going to have some significant problems. So in the old days, and in places where maybe they don't have quite these resources, what happens to these children? Unfortunately, often they were sent out to pasture. They'd pass on. And it's a real shame, but that is oftentimes we just didn't have anything to offer. But now in 2024, we do have the ability to do these things. We're able to do the large surgeries. We're able to virtually plan them beforehand. But sometimes you get a little bit further down the road, and despite doing the surgery, you get to the situation you can't get the breathing tube out. In which case we look and we see, well, there's still problems. In which case we use our 3D models to be able to determine how to best approach these. We can place stents, we can place splints. We can take it to another level and be able to actually custom mold around the surgical guide. Ultimately, what it does, the idea is that we can use a combination of the techniques using our 3D imaging, using our surgical guides, using our entire armamentarium to be able to move forward and be able to do the surgeries that we need to be able to take care of the kids in the way they need in order to be able to get open airways that allow them to breathe. Ultimately, even make it to Good Morning America, if in some cases. This is one of my favorite cases in recent memory. This was a child who had undergone complex heart surgery and ultimately got to a situation where they had to place a stent to basically open up one of the blood vessels. The stent is effectively a metal conduit that helps keep the blood vessel open. Unfortunately, when that stent was deployed in the blood vessel, it crushed off the airway. This demonstrates a close-up of the stent, and you can see that the airway is effectively obliterated. This is an endoscopy photo looking down. This is the normal right side. And then what we're going to do, we're going to come back and we're going to take a look at the left side. And you're going to see, as we saw in the 3D image, this area is completely mashed. So this child is not able to really use their left lung. So we return to our days of doom, and here we are in the cardiac catheterization lab where we have control of the stent through the blood vessel that is being obtained through the child's leg, and we are approaching from the airway. And ultimately what we were able to do is, using a combination of instruments, be able to bend the stent that was in the blood vessel around the airway itself. This allowed the airway to be opened up just enough to be able to get air down and be able to start using the left lung. We were able to confirm that we deformed the stent as we expected on 3D imaging, and then we were actually able to take pressures across either side of the stent to be able to understand that there was no decrease in the blood flow that was necessary for the heart. So I could talk about this stuff for hours. The reality is that the future is now. Taking what we've learned over the years, whether it be from video games, whether it be virtual reality, whether it be just pop culture in general, and be able to see what the movies bring to us and be able to apply it to what we do in medicine, it's just been a fascinating road. We really need to press on, and we need to let only our imaginations hold us back. I'm certain it's going to continue to get better and better, and I look forward to as we push through in my lifetime and in our children's lifetime, because that is the whole goal of what it is that we do here at Rady Children's, is to be able to build the future and be able to take these kids and hope that they are going to be the ones that take us to the next level. So thank you all for your time. I hope you enjoyed the panel, and I know that I most certainly did. And please let us know if you have any questions.